Let's just dive right into today's medical explainer with a classic clinical mystery. We are going to look at a condition that is an absolute favorite for medical exams and clinical rounds today, mostly because missing it in the real world has devastating consequences.
Okay, I want you to picture this case. An 18-month-old boy is brought into your clinic. He's had this high, totally unyielding fever for 10 straight days. You look a little closer and you notice he's got severely cracked, dry lips, his hands are a bit puffy, and there's a diffuse rash spreading right across his trunk. Salam, welcome to a Little Push 5 Minutes Medical Mnemonics. I am here to help you lock down the key diagnostic criteria for this exact scenario.
So if you guessed Kawasaki disease, hit the nail on the head. You are absolutely right. Kawasaki disease is a medium vessel vasculitis. Now, this is incredibly high yield for your exams, and honestly for your actual practice, because it is literally the leading cause of acquired heart disease in children in the United States and Japan. So how are we going to perfectly recall the clinical findings that have to be present to diagnose it?
Well, we're going to use a mnemonic, of course. Let's break down the legendary crash and burn criteria.
We start with C for conjunctivitis, and what's actually really interesting here is the specific type of conjunctivitis we're dealing with. It's classically bilateral and non-exudative. And all that means is there's absolutely no goop, no pus, and no heavy crusting in the child's eyes. It's just this dry, red injection that usually pops up within the first couple days of the fever. All right, let's move to R. R stands for rash. Specifically, you're looking for an erythematous polymorphous rash. And look, polymorphous just means it can take on a bunch of different forms, but a super key clinical pearl to remember is that it's non-vesicular, so absolutely no blisters. It frequently starts right on the patient's trunk, usually at the same time as the fever. Next up is A for adenopathy. Now, this isn't just any swollen lymph node, right? It classically presents as acute unilateral cervical lymphadenopathy. So you are usually looking for a single prominent, really large lymph node right in the neck that is strictly greater than 1.5 centimeters in diameter. Moving right along, S represents the really famous strawberry tongue. The mucosal changes here are visually striking. Alongside that bright red, bumpy tongue with prominent papillae, you're also going to see diffuse oropharyngeal erythema and really painful, dry, fissured lips. Then, H is for hands and feet. In the acute stage, so we're talking around days 3 to 5, you'll initially see induration, redness, and swelling of the palms and soles. But you got to keep in mind, in the later subacute stages, which is usually 2 to 3 weeks after onset, this actually progresses to desquamation. And that's just a fancy word for the actual peeling of the skin, right at the tips of the fingers and toes. Okay, so those 5 signs make up the crash. Finally, the burn part reminds us of the whole anchor of this diagnosis, the unyielding high fever. We're talking about a fever often spiking over 104 degrees Fahrenheit. It lasts for at least 5 days, and it notoriously resists normal antipyretics like ibuprofen or acetaminophen. To actually diagnose Kawasaki, you generally need this 5-day fever plus at least 4 of the 5 crash criteria. So we've got the criteria down. Let's pivot and look at some absolutely crucial high-yield clinical correlations. You gotta always remember your demographics here. A massive 80% of Kawasaki patients are children under 5 years old. And while sure, it can happen in any demographic, it's predominantly seen in children of Asian descent. Now, the single most important reason you have to immediately recognize Kawasaki disease is the terrifying risk of coronary artery aneurysms. If you leave this untreated, up to 20 to 25% of these kids will develop inflammation and dilation of their coronary arteries. And that can lead to thrombosis, myocardial infarction, and yeah, it can be totally fatal. You should always suspect Kawasaki in any child who suffers a heart attack. And because of that terrifying, killer complication, you absolutely must perform a 2D echocardiogram right at the time of diagnosis. But obviously, you don't stop there. You have to repeat it at strict intervals, usually around 2 to 3 weeks, and then again at 6 to 8 weeks, just to continuously monitor the heart for any structural damage. And that actually brings us to a really massive treatment exception. Normally, the golden rule in pediatrics is you avoid giving aspirin to kids during viral-like illnesses. Why? Because of the severe risk of Ray's syndrome, which is a condition causing liver failure and encephalopathy. But Kawasaki disease is the rare high-yield exception. Here, high-dose aspirin paired with intravenous immunoglobulins, or IVIG, is your immediate first-line treatment. It rapidly reduces inflammation and prevents that permanent heart damage. All right, let's lock this into your long-term memory with a quick rapid review quiz. I'm going to read the question, and I'll give you a few seconds to think about it before I reveal the answer. Ready? Let's go. Question 1. What specific type of conjunctivitis is seen in Kawasaki disease? Take 3 seconds. 3, 2, 1. The answer is bilateral and non-exudative. Remember, absolutely no goop. If there's heavy pus, you might be looking at a totally different diagnosis. Question 2. Why must an echocardiogram be mandatorily performed on these patients? Think about it for a few seconds. 3, 2, 1. You absolutely must echo to monitor for the life-threatening complication of coronary artery aneurysms. Missing this is the single most dangerous pitfall of this disease. Okay, our final crucial question, what is the high-yield first-line treatment for Kawasaki disease? Think back to that major pediatric exception we just talked about. 3 seconds. 3, 2, 1. It's the pediatric exception. High-dose aspirin to handle the inflammation and prevent thrombosis, combined with intravenous immunoglobulin. I really hope this helps you crush your exams and recognize this absolutely critical condition early in your clinical rounds. Consider this. By simply remembering a catchy mnemonic like crash and burn, you actually hold the power to prevent a toddler from developing lifelong heart disease. It kind of makes you wonder, right? What other life-saving pediatric exceptions are hiding in plain sight, just waiting for you to discover them? Keep that passion for learning alive. Subscribe to A Little Push for more 5-minute medical mnemonics. Until next time, salam.